Hello, my name is Evan Turner. I'm here today to talk to you about how to utilize VELscope in your practice, not only on your patients, but how to incorporate it into your practice as well. It's very important to understand that VELscope is a device to assist you in identifying abnormalities. This is not a magic oral cancer screening wand, if you will. But at the end of the day, we know that if we can identify early changes, we can prevent those changes from becoming oral cancer. So at the end of the day, this is another tool that you're using, just like a lot of other tools that you use to try to prevent disease. That disease could be periodontal disease, it could be tooth decay. But at the end of the day, you do things every day in line with prevention. And this is just another opportunity to prevent something that we believe is probably the most important thing you can do for your patients, is to prevent oral cancer from ever occurring. And hopefully VELscope plays a role in that. So why, if you will, are we here? Why is VELscope something you incorporate into your practice? It's hopefully because you believe that we have an opportunity to reduce the deaths associated with oral cancer by finding these changes in this disease much sooner than expected. If you look at the rates of oral cancer, unfortunately, especially just over the last 10 years, we see a significant increase. And the scary thing is that increase is associated with patients that are younger and younger. It's not the 80-year-old smoker, it's now the 25-year-old healthy marathoner that unfortunately is being diagnosed. And it's important to understand, why is this the case? Why are we seeing this slope that's showing a significant increase in oral cancer? We know, and we truly believe, it's because of a virus now. But also we know that at the end of the day, patients are just not educated about this disease. They think it's a smoker's disease. They don't think it impacts them. And to be quite frank, many in the medical community as well are not truly cognizant of how prevalent oral cancer is. One of the things I would ask yourself, and something that you may want to engage with your patients, is ask them, what do you think are some of the top 10 to 15 cancers? And most patients will say lung cancer, cervical cancer, breast cancer, skin, prostate. They'll never put oral cancer in that category. And again, it's because it's just not a disease that we hear very much about. And I think probably because that's in the purview of dentistry. The reality is that something that women are very familiar with, which is cervical cancer, there's 4 times as many oral cancers than cervical cancers. So one thing to understand in this comparison is 2. The first is the impact of screening. At one time, almost 50 years ago, cervical cancer was the leading cause of death among women. And now it's, I think, 25 or 26 and the less. The other thing that we know, though, is that like cervical cancer, oral cancer is now caused by a virus, the HPV virus. And again, something that many of your patients are completely unaware. But in this conversation you can have with your patients, we truly believe it's something that they can understand, because they know that a pap smear is identifying changes most likely associated with HPV. And from that, HPV now has become, as it has become, a leading cause of oral cancer. There's no way to truly identify it, but we can identify the changes associated with HPV that could be potentially, hopefully, in a precancerous state. The one thing that I would stress is, as you're doing your examinations, and whether it be VELscope or under white light, make sure you get exposure. Exposure is the key to identify these changes, because they tend to be further back of the throat, posterior lateral border of the tongue. So it's really important that you're pulling that tongue to where it's uncomfortable and you're getting a big because we have to see as far back as possible to identify changes. So whether you have a VELscope or not, if we're not getting exposure, we're not going to identify these changes that could be life-threatening. From that, a lot of the initial studies associated with HPV and oral cancer was associated with oral sex. But what recent studies have shown, that the virus can be transmitted through open mouth kissing. Why is this so important? It's because everybody's at risk. It doesn't matter how promiscuous you are now. The reality is that if you're a normal 18-year-old, 16-year-old, you in theory could be exposed to the virus, which means when it comes to your patients, you have to identify everyone as being a high risk category. Again, over 40, you're smokers, you're heavy drinkers, who does not have a poor diet nowadays, lack of sleep, and now HPV. This represents 90+% of your patients, which means you need to be screening, at least offering this every single patient that you deem as being an adult. So who are we going to screen? We just talked about it, but how frequently? It's going to be at least once a year. Again, doctors, you can screen more frequently if you have patients that you believe are a higher risk category because maybe they think that they've been identified as HPV positive. Obviously, that's going to be females because they have history of cancer in their families. They are smokers or drinkers. So standard is once a year, but again, if you have a patient that's of higher risk, it's okay to screen them more frequently. So this is probably one of the most important slides of this whole presentation because it relates to a key understanding that VELscope is part of your overall examination. This isn't replacing anything. It's just giving you more information in that total process. So patient comes in, we have an updated history form, maybe some medications change that obviously leads you to the fact that maybe oral abnormalities could persist associated with certain medications. Now we have a Q&A with the patient. Anything new, different since your last visit? We now do an extraoral examination. Then we do an intraoral white light examination. Mr. Smith, I noticed something at the roof of your mouth. Do you know if you did anything, like maybe utensil, a chip or something that caused some trauma? Don't know. So obviously we're going to record that for further examination with the VELscope. We now do our VELscope examination, same process that was did the white light in, one side, vestibule, cheeks, floor of the mouth, tongue, lateral boards of the tongue, palate, back of the throat. Mr. Smith, I noticed something on your cheeks. Do you know if you're biting your cheek frequently? Oh, okay, yeah, so it makes sense. And then obviously we're going to talk about how we assess trauma and inflammation versus something that could be of greater concern, or maybe there's something that identifies as abnormal that we're not sure, patient's not sure. We go through this process of assessment, which includes a 2-week follow-up still there. And then obviously part of that treatment plan could be to refer to a specialist for review. But the key is you have to have all this other information to assess what to do next. It's really important. If you're not, then you're missing on critical information that could be critical to assessing, is this worth referring or not? So again, VELscope is one part of all this information that you will need in order to determine what the next steps are for your patients. At the end of the day, 30+% of your patients have some form of abnormality. That abnormality, in most cases, you identify as being benign, a fibroma, a cheek bite, what have you. But it's critical that if you're not sure, you get a diagnosis, whether it's through VELscope or not. At the end of the day, if you don't have a diagnosis, you're not going to know how to appropriately treat. If anything, hopefully VELscope is going to assist you to confirm that many of these lesions you see every day are actually benign, and those that are more suspicious, we reinforce that suspicion, if you will, to determine that a follow-up is going to be required. So I want to step back a second and ask you to think about in this process and making the assumption that you're going to charge for a VELscope exam. The patient declines. Our normal inclination is that they're declining because they don't want to pay for it. But we don't want to make that assumption. It's always critical that we ask the patient why. What are your concerns, Mrs. Smith? Why is this something that you don't want to have, which we believe is really important to have as part of our standard of care? And so one of the reasons is sometimes because they've never heard about this before, they think it's maybe a gimmick. If it's about oral cancer, why isn't my physician offering this? So one of the things you can respond to that cynicism, questioning about the technology is confirm and let them know this is FDA approved. This is actually meant for us to use to assist us in identifying abnormalities, preferably at an early possible stage. And you can use other reference like a Pap smear, like a mammogram, PSA, what have you. But it's actually geared for people like us that do a thorough oral health exam on a regular basis. And it's so effective. This is used by now surgeons to assist in identifying changes. And this actually comes from the medical industry where it's used for lung cancer screening. So you can inform them this has actually been in medical applications for almost 20 years. At the end of the day, though, your goal is to find things early. If we look at most oral cancers today, which really hasn't changed for almost 30 years, most oral cancers are found at a late stage, stage 2 and greater. As with any form of cancer, if you find it too late, your mortality rate doesn't change, which is a little less than 50%. That's because you find it when it's at the surface, when we can see it. Obviously, in order to prevent oral cancer, we have to actually find it before we can readily see it in a dysplastic phase, which is below the surface. And obviously that's where VELscope comes into play. By finding it early, by finding it below the surface, we can identify it and remove it, and again, prevent it from becoming a obviously more serious form of dysplasia and potentially cancer. So back to the question to the patient. Ms. Smith, can you help me understand what are your concerns? Why don't you want to move forward? One of the concerns is that they may think that there's pain or radiation. So if they say, well, didn't you just give me bite wings or radiographs? I'm concerned about radiation. And so if you get any type of response about concerns to their health, inform them, Ms. Smith, this is completely safe. There's no radiation. There's nothing that's going to cause damage to cells. It's painless. It's fast. All we're using is a safe blue light that has a certain intensity that allows us to get below the surface and identify if the tissue is normal or abnormal. And you can say it, it's really that simple. For your information, what we're specifically doing is we're exciting the collagen predominantly in the basement membrane. And when that collagen is normal and healthy and in a cross-links condition, it absorbs that blue light and actually gives off a response. That response is called fluorescent. You can't see with the naked eye, but through the filters in the handpiece, we capture that response. And when it's normal and healthy, it appears green. When we have dysplasia or cancer, what it starts to do is break down that collagen. And once that collagen starts to break down, it can no longer fluoresce. So instead of seeing green, we see dark or black. It really is that simple, but it's so impactful in terms of providing guidance to you as to sort of what direction you're going to pursue when it comes to care for the patient. So these are all the things that are involved in assessing if the tissue is normal and healthy. Again, collagen, we actually see proteins in the cells are indicative of increased metabolism associated with cancer or dysplasia. So besides dysplasia and cancer that are going to appear dark or black, two other things that will appear dark that are benign, which is melanin. So African Americans, Asians tend to have more melanin, for instance, in the tissues and gums. And then hemoglobin, which is in blood. Hemoglobin absorbs its wavelength, but it is a great tool for us to actually assist in determining if tissue is traumatized or if there's inflammation versus something that could be more dysplastic or cancerous. And we'll go through that in a second. So 98% of the time, all you're going to see is healthy green tissue. If you notice the vascularity, and so that's the hemoglobin that I referenced. Sometimes you'll have some patients that it's almost purplish in color under white light, this increased vascularity, and it's going to show up as darker under VELscope. But again, we're always using that criteria, bilateral presentation and so forth to confirm, obviously, if something is of concern or not. I mentioned bilateral. So all the tools that you use every day under white light to assess concern or not, abnormality or not, is unilateral, irregular shape, persists for 2 weeks. And we're using those same criteria. So here you see a little redness in the tonsillar area. Under VELscope, this will probably be more pronounced. So you see dark, but you notice it's bilateral. So what I would suggest is use this as an opportunity. Hey, Ms. Smith, I noticed there seems to be a little inflammation in your tonsils. Do you have any allergies? Something that's causing irritations. And why is this important? Because you're talking about soft tissue, right? Make sure you utilize the opportunities to talk about soft tissue so patients understand you are about oral health. You're not just about teeth and fixing teeth. You're about making sure that the total oral health, which includes teeth, which includes gums, which includes tongues and soft tissue, are in good condition. So if I put VELscope in your hand for the first time, I said black is bad. Didn't know anything about it. And all of a sudden you're seeing this tongue and evidence told you black is bad. You might be thinking, oh my God, this patient doesn't have too much to live. But then your keen understanding of how dysplasia presents itself kicks in, and oral cancer doesn't form randomly. It doesn't form in polka dots or little circles. It's going to be unilateral, irregular shape, right? It's going to persist for a while. But what you do know is that hemoglobin absorbs this wavelength. So what we're actually seeing is increased blood flow to our taste buds. In some patients, this will be more prevalent than others. Here we have an example of a lesion on the back of the throat And that's his concern, right? This should be green. What's going on? Mrs. Smith, I noticed something in the back of your throat. Do you have allergies, postnasal strips, something that's causing some irritation? The patient's like, nope, not really. You know what, let's have you come back in a couple of weeks just to see what's going on. Patient comes back, no change. We're still seeing that dark mass. But one of the things I want to stress to you, if you really start looking, you start seeing a lot of little black masses all throughout the back. And obviously, if I opened up this picture, you see black masses throughout the back of the throat. So that reduces our concern because, again, we know cancer doesn't grow that way. But wasn't resolving, patient gets referred to an ENT. ENT immediately takes a biopsy. Like, I don't know what this is, but there's something going on. The only way to confirm is biopsy, and it comes back as inflamed lymph node tissue, which is fantastic, meaning it's not cancer, but it wasn't resolving. Patient ends up being diagnosed and tested for severe acid reflux. Why is this so important? Acid reflux, or excuse me, esophageal cancer caused by acid reflux is actually one of the fastest growing cancers in the US. So why is this so important? Because you have the opportunity to identify this, have a conversation with the patient, and make sure they're getting appropriate care. This is pretty severe. You can see how forward these lesions are. This is actually something that's more common with acid reflux, where you see actually these polyps right in the back of the throat. You see that, make sure you have the conversation with the patient about if they have acid reflux, are they treating it? Maybe the medication they're taking isn't effective. Maybe they're not taking it regularly, but make sure that they're following up with their primary care physician to address this issue, because this is a severe issue that needs to be obviously taken care of. So one of the things you're going to see very frequently is orange or red, especially on the dorsal surface of the tongue. It has nothing to do with cancer. It's a bacterial response for hygiene. This is a great tool. Take a picture, show the patient, talk about how you have ways to improve their oral hygiene to where we can reduce this porphyrin response. We can talk about that in a little bit. So one of the things you're going to see very frequently is white or light green in color, and that's just hyperkeratosis. It's the benign state, which is great. But what I would ask you to do is just don't say to yourself, well, green or white is good. Let's figure out what's going on. Are there some sharp edges maybe that's causing this irritation? Here, the patient's tongue was getting caught between their teeth frequently, and VELscope identified that area, which therefore then doctor removed and obviously made it a lot more comfortable for the patient. I mentioned pigmentation absorbs this wavelength. So African Americans, Asians, and really what you need to do, obviously we know what pigmentation looks under white light, and it should pretty much correspond to what we see under VELscope. So let's say we have an abnormality that we see under white light, right? Or under VELscope, doesn't matter, but we see something abnormal, it's darkish in color. How do we differentiate these lesions that are traumatic or inflamed versus lesions that could be dysplastic or cancerous? So one of the techniques that I want you to think about and incorporate every time is a blanching technique. So when we see something abnormal, take your explorer, turn your mirror around, use the little skinny part of your mirror and gently rub across it. And if you notice here,
open up a little bit bigger. There we go.
You see the hygienist is rubbing across it, and it's turning green.
Okay. Set it to stop recording.
So that green now basically tells us we're moving the blood out of the epithelium and seeing a nice healthy basement membrane. So there's blood here based on trauma and specifically a denture sore that obviously is caused some inflammation, and therefore we adjust it, and this should resolve after 2 weeks. If we rub it across and it stayed dark, that definitely increases our concern that this could be something more dysplastic or cancerous that requires appropriate follow-up. So this technique is going to resolve 98% of all the abnormalities you see. And once you see it, you're going to begin to notice a difference. These tend to be more grayish in color, sometimes maroonish in color too, when it comes to an inflamed, irritated area. Critical important point though, we have to have a basement membrane to blanch across, right? So if we don't have a basement membrane, all we're seeing is blood-filled stroma. So ulcerations, wounds, cuts, things that would have caused by trauma, for instance, that has exposed that stroma, it's just going to show up as dark under VELscope. So make sure you follow your normal clinical protocols. And again, better safe than sorry if you're just not sure what the lesion could be. Not uncommon to have irritation due to, sharp edges, malocclusion. Here we see a dark sort of linear area. Now, again, Cancer is not going to grow in a line, right? These tend to be bilateral, and when we rub across it, it tends to turn green. Great, so we know this is just irritation. But what I want you to do is take this information to the next step. Mrs. Smith, we've been talking about this crown for the last 2 years, and let me show you. See this black here on your tongue? This is irritation. Irritation can lead to changes that we really want to avoid. Let's get you scheduled next week to get this crown taken care of. Or, we've been talking about Invisalign for a while to maybe open up your bite, or we have this tool called Invisalign can open up our bite and hopefully reduce that inflammation that's being caused by your bite and obviously causing irritation to your tongue. So think about if we see this irritation, let's just not blanch it and say, oh, it's green, it turns green, so it's not cancer. What can we do to resolve whatever is causing that? And then think about those steps. And again, it provides a great opportunity for you to sell, if you will, or offer your products. And I say sell meaning sell on your treatment protocols or benefits, but then also obviously it's a benefit to the patient by eliminating that irritation. Most common thing you're going to see with VELscope is irritation, so cheek biting or cheek sucking. Again, these will blanch pretty easily. These tend to be bilateral. If you have a patient and they're biting on the cheeks all day long, it may not blanch because it's this trauma that's unfortunately has been had, like a hematoma that unfortunately is through the basement membrane. So it's critical that for your patients that are cheek biting more aggressively, recommend get them into some type of night guard or something that's going to reduce that trauma, so you can make a thorough assessment. Is that tissue normal or something that needs to be looked at further? So we have to have a diagnosis, and it's really critical. So on the left, we see a lesion. It doesn't look overly, or it doesn't look normal. And then on the right, under VELscope, we see dark, but when we rub across it, it turns green. So, hey, it turned green, it's inflamed, no big deal. No, let's make sure we get a diagnosis, because we're going to treat erosive lichen planus differently than we're going to treat candidiasis. So it's really critical to understand VELscope is part of your white light examination. Just like wearing loupes helps you see better under white light, VELscope helps you see better, but it's, again, part of this overall assessment. So if a white light lesion does not look right, regardless if a lesion blanches or not under VELscope, make sure you follow your normal protocols. And if you don't know what it is, make sure you find out with their referral consultation. So this is the lesion, if you notice, does not blanch. This is the left lateral border of the tongue. And from that, if you notice, as the hygienist is rubbing across it, it stays dark. But what do we notice first? We notice these lesions, and again, cancer is not going to grow in sort of this linear dot motion. But before they even pulled out the VELscope, they did a white light exam, pulling on the tongue. They noticed, Ms. Smith, I see some dark areas on your tongue. Do you know how long they've been there? And actually, dark red is specific color. And the patient, oh yeah, I bit the hell out of my tongue last night. So obviously, now we look on a VELscope that correlates. The reason why they're blanching this larger area, because that's more of an irregular shaped lesion. The patient wasn't sure if it was there before they bit their tongue or not. So to play it safe, they have the patient come back in 2 weeks and it resolves. So we're looking at an ecchymosis or a hematoma, if you will, that sort of breaks through the basement membrane. But usually when you have this type of trauma, patients remember to where you were able to connect the dots to say that it's something that is no big deal. But again, better safe than sorry. Have the patient come back in 2 weeks just to make sure. So we have to know what we're looking at. So pigmented lesions are not going to blanch. So amalgam tattoos, we know what those are. They have that bluish hue. So just be cognizant that it's going to stay, dark under VELscope. When you do blanch a lesion, make sure you blanch the entire lesion, up and down, left and right. We want to see that entire lesion turn green. And if it doesn't, investigate further, because you could have inflammation associated with dysplasia. So one of the concerns that you may hear, especially referred to an oral surgeon, for instance, oh, there's too many false positives with the VELscope. And in all fairness to our specialists out there, especially 12 years ago when we launched the technology, I don't think did an effective job in training our clinicians in terms of how to appropriately assess a lesion. And so if you're referring anything that's dark, even if it's a denture sore, then yes, you're going to have some surgeons that are going to be annoyed, let's just say the least. But now when we use our protocols, unilateral, regular shape, persist for 2 weeks, and we incorporate that that blanching technique, you should have a pretty good sense this is something that needs to be assessed further. And the great thing is we can take a picture and send that for some guidance before you even refer out. But at the end of the day, what we do know is if you follow these protocols, there's something that warrants a referral. There's something that warrants a diagnosis. And God willing, hopefully it's not cancer, but it's really important. There's this perception that if it's not cancer, it's a false positive. That's absolutely false. A true false positive is normal, healthy tissue that appears abnormal. Again, normal, healthy tissue that appears abnormal. When you have something abnormal in a VELscope, there's generally a reason for it. It may not be cancer. It could be, again, erosive lichen planus that will blanch. It could be candidiasis. It could be an ecchymosis. It could be one of 100 different abnormalities as deemed by the American Academy of Oral Pathology that may require biopsy for diagnosis. So at the end of the day, our goal is to identify an abnormality and then determine if that abnormality requires further assessment, which may or may not include a biopsy. So we sort of talked about abnormalities, and obviously things that are abnormal that you have to really assess to determine this is something that warrants referral. But at the end of the day, you're going to find most of the things that you see are going to be pretty straightforward. So here goes a little white squiggly area. You may or may not be concerned about this under white light, but you're definitely concerned out of VELscope. Again, this is unilateral. It's irregular shape, does not blanch. Patient comes back after 2 weeks, it's still there, hasn't changed shape or size. So it's really important. How do we know it's not changed shape or size? Because we took a picture of that lesion the first visit. When they came back, we took another one and we were able to compare the pictures to say this is not shrunken, if you will, at all. And then lastly, in both visits, it did not blanch at all either. So at that point, we're left with, I don't know what it is, and this requires further follow-up. The specialist determined that a biopsy was warranted, and upon biopsy, it comes back to CIS, which is fantastic because we caught this at that transition phase between dysplasia and cancer, which means we're not gonna have to deal with radiation or chemotherapy. Obviously, this has to be excised, but we're not gonna lose half our jaw either. This patient was referred for the polyp, and thank God they had the polyp, because if it wasn't for the polyp, they may not have found the dysplasia and the CIS located adjacent to it. Again, following those standard protocols, unilateral regular shape persists for 2 weeks and does not blanch. So for those that have denture patients, one of the things that's important is that you get these patients in every year, at least once a year, because invariably, you're going to have that patient that I'm sure doesn't come up until, or doesn't want to come in until it doesn't fit anymore. And I've heard the horror stories where it doesn't fit because there's fortunately a cancerous lesion underneath the denture. So this doctor was initially concerned about the red areas in the vestibule, did his VELscope exam, and was adamant, Mr. Smith, I want you to come back in 2 weeks after adjusting the denture. So you can see how that adjustment sort of changed a little bit, because here now we see a little dark area, and that's associated with the ridge of the denture, but it turns green. So we know it's just irritation, which again, we can make some additional adjustments. But this was the reason why the doctor wanted the patient to come back. It's right there on the ridge, and that area ends up being biopsy confirmed as severe dysplasia, which is again fantastic because we're not going to lose half our jaw, and most importantly, we caught it at an early precancerous state. So these leukoplakias, these tend to be lesions that are put in observation mode because most of the time, fortunately, they're benign. But the problem is sometimes when it starts changing is when it's too late. These were actually 2 lesions that were in observation mode for over 2 years. This first one we're not observing anymore. Again, unilateral regular shape persists for 2 weeks, does not blanch when we rub across it. And fortunately, we caught it at a severe dysplasia phase, which means, yes, we're going to remove that top layer, but we're not going to lose half our tongue. But the reality is most of the lesions that we do see are end up going to be benign. So hyperkeratosis, linear lichen planus will be green or a light green in color that tells us it's benign. Now, I stress, just because this lesion shows up as green does not mean we ignore it. Doesn't mean, okay, let's go to the next thing. What it means is we're going to mark it in the chart. We're going to look at it. Is it caused by maybe a sharp cusp? Is it caused by allergies? Is the patient maybe biting on their tongue in some way? So we always want to figure out what the cause of that abnormality is and try to address it. Let's say that we're not sure, it doesn't resolve after whatever your protocols are, 6, 12 months. Our recommendation is refer. It's even if we know it's benign, it's okay to refer. We're referring for consultation and just confirm that this lesion is completely benign. But also, you never know, there could be underlying health causes for that physician may be able to, or an oral surgeon or ENT may be able to identify. So this patient was referred to NYU to the oral medicine department for the hemangioma in the lip, and then we pull out the VELscope, you see the dark area. And the reason why I really like this is because, or this particular slide or patient, is because in this case, the dentist didn't notice the slightly raised area here. But you are not missing it here. VELscope increases your sensitivity by almost 64%. That means if you turn on this light, look through the light into the oral cavity, and there is a form of abnormality, you will see it with the VELscope. Now, let's just say that in this case, you saw this, wasn't sure, you're charging for it. The patient says, no, that's okay. My suggestion, hey, Mr. Smith, we care about you so much, we're going to do this anyway. And the reason being is by the normal protocols, unilateral regular shape persists for 2 weeks, does not blanch. This was and ended up being biopsy and was confirmed as stage 1 squamous cell carcinoma. So, from that, yes, it's a cancer, but fortunately it was caught at an early stage versus a late stage. So this is our goal, right? We don't want to find cancer. We want to find dysplasia. And this is a phenomenal example of how VELscope can assist you in finding the earlier stage dysplasias, which means, again, not only elimination, hopefully, of ever becoming cancer, but also the morbidity associated with the treatment of these precancerous and cancerous lesions. If we can obviously just remove this lesion, we're not going to have to get in the muscle, and obviously it's not going to be as an extensive a surgery. Again, a lot of things you're going to see actually will present themselves as benign. Again, erosive lichen planus, lineable lichen planus, or hyperkeratosis. So a last famous picture. And I think this in itself attests to the challenge that you have as clinicians to screen for this hideous disease. And the reason being is, generally, again, those changes don't occur till, or we generally are not finding these changes until they're closer near the surface. But that's the problem. When they're closer near the surface, they're already potentially a late stage cancer. But now with VELscope, we're identifying this lesion, but this is already a cancer. So again, this just tells you the challenge that you have, because if it's already a cancer and we can barely see it, how do we see things with a normal white light with for a precancerous lesion? And obviously, if this was a patient that we had seen earlier, maybe we would have caught it at a dysplastic phase as opposed to a carcinoma phase. But at least this is still a low-grade mucoepidermal carcinoma as opposed to a high-grade. So critical aspect. So when we first launched this, the VELscope, you would see the lesion on the right, and then you send it to a specialist who didn't have a VELscope. It's like, I don't really see anything. I don't feel comfortable taking a biopsy. And then you're in this quandary. What do we do? How do I take care of my patient? What if my patient has cancer? And so the way we addressed that was to develop this iPod with a special attachment that attaches to the back of the VELscope. It's magnetized. And from that, by using now the iPod to assist in taking pictures, we can now download that in a HIPAA compliant manner. We can store it on the iPod, obviously download it into the patient's chart, email that picture to the specialist. So now when you have that that picture, or the specialist has that picture and says, hey, here's this area of concern. What we found is that those issues of not knowing what to do have been dramatically reduced, because the oral surgeon knows if there's cancer and I don't take a biopsy, even though I have a picture that shows it, it doesn't put me in a good space. So photo documentation is so critical, both for you in terms of managing those patients from one visit to the next, has it changed size, has it changed shape, to communicate to patients, and we'll talk about that a little bit further, and then obviously to communicate outside of the practice if necessary for a potential referral. So I mentioned communication with the patient. So I stole this from a practice who offered Oral B, I believe it was, but whether it be Oral B or Sonicare. And what they were doing is doing a VELscope exam. They see the red, take a picture, turn it off, show the patient, on the iPod red, and say, Mrs. Smith, you see this red? This is called porphyrin, or in layman's terms, bacteria poop. And the problem with this waste, it gets in the nooks and crannies of the tongue, and with your manual toothbrush, it's just really hard to get in all those nooks and crannies. And that's why using our mechanical toothbrush or Oral B or Sonicare, it's just so much more effective in cleaning your tongue. But obviously, it's not just your tongue; it's also that bacteria in your gums, right? And which is obviously one of the things that we also recommend. So showing that picture, and I have to say, using the word poop really helps in relaying the message to that patient about the potential of the tools that you offer in terms of benefiting them when it comes to improved oral health. One of the things we're really excited about that seems to be growing in terms of evidence is this correlation with this porphyrin and sleep apnea. So what we're finding is, or I shouldn't say, but clinicians who are now utilizing this is when they see the red, then it says, Ms. Smith, I see what we call porphyrin, which some studies are now showing a correlation potential with sleep apnea. One of the things we want to do is, let's do some further assessment, fill out an evaluation, Epworth score, what have you. And then the only way to confirm is to get a sleep test. But again, it's that visual interaction with the patient to show them this could be indicative of sleep apnea, this red color that I think helps, at least from the feedback that we're getting from doctors, helps the patient understand or connect the dots that this could be associated with a life-threatening disease. So for your information, and in case for whatever reasons you have that 1 in 1,000 patients that needs clinical evidence to support it, go to our website. There's 30 plus years of studies, or 30 plus studies based on 15 plus years associated with fluorescence and the efficacy and the proven abilities to identify precancerous, cancerous lesions that obviously could be life-threatening. So one of the things that I want to make sure that you do is that we're utilizing the technology first in your own practice. So as we end this, I want to make sure use this on each other before you start using it on your patients. But from that, understand that the learning curve is about you being comfortable with it. It's not about what you're seeing. It's just getting comfortable with your angles, your distance. So first and foremost, we have our VELscope. We're going to put our little plastic sheath over the VELscope. The mirror side faces the patient. We're looking at the other end. We then put a paper cap over that mirror side, and the mirror side facing the patient. We're going to be 2 to 3 inches or closer to the oral cavity. As we get further, that light's not going to be able to penetrate. So again, 2 to 3 inches, turn the on-off button in the front once, and we're on. Up and down, left and right, for the mouth, back of the throat. This light is not like a curing light, so you're not concerned about damage to your eyes, but it is bright. So if you shine in your light, if you've tried it yet and for whatever reason pointed it the wrong direction, you may see some stars. So we provide goggles for the patient for patient comfort, but again, this is not like a curing light, so you don't have to be concerned. One of the things I would stress is we want to make sure that, again, we've done our white light exam first, we've palpated externally, obviously intraoral exam, both to identify changes, but again, part of the protocol. It's really important if you wear loops, you're going to establish your normal distance first with your loops, and then you're going to bring the VELscope in. So you're going to still maintain your normal distance, but bringing the VELscope in between allows you to utilize your loops just like you normally would doing your examination. Up and down, left, right, for the mouth, back of the throat. Once you get comfortable, again, 5 to 10 patients, it shouldn't take more than a minute, max minute and a half. There's something that you need to follow up with. And from that, you're done. One of the things I would stress is let the patients know ahead of time before you start. Mrs. Smith, you're going to hear a little fan, you're going to feel a little warmth, but it's completely safe. There's no radiation, nothing to cause any distance or pain or damage to cells or pain. It's just a simple blue light that helps us see better, something of that nature. I guess I would stress, and here goes an example of a clinician. You see the distance. So if you're wearing loops, that's how you're wanting to maintain that normal distance. If you can turn off the lights in the operatory, great. The darker the room is, the greater contrast you're going to see. But it's meant to be used in a fairly lit operatory because we know just some practices can't turn off their lights. The only thing that I find is if you have maybe an open bay window and the sun's coming in, if you can definitely pull down the shades or at least use your body to sort of get between the patient and that light source to help reduce that ambient light. Lastly, one of the things I want to stress is the disposables obviously have 2 points. Obviously, we're trying to reduce transmission of viruses and diseases, obviously. But the other thing is the corrective VELscope. So this lens here has no seal. So we never want to use any type of liquid, cavicide, alcohol wipes in here. Please. The number one reason why we find damage to this is because unfortunately liquid has gone behind this and ends up killing the LEDs, and it's a pretty hefty repair. So we can avoid that by, again, using a cap after every patient. If you find that there's any dust that collects in there, just wipe it down with or with a dry lint-free cloth. But again, no liquids either in the mirror edge or on the base where the charging portion goes in. If you feel like you have to wipe it down, squeeze out that towelette, if you will, that you're using, and then again, wipe the outside only. So it's a code for reimbursement, D0431. It's sort of spotty in all honesty. Probably nationally, we see anywhere from 20 to 25%. Some areas are higher, some areas are lower. But what's critical is to understand it really doesn't matter if insurance covers or not. What matters is the value to the patient or the perceived value that the patient has of the technology and your fee. Normally we find that once you start hitting that $35 to $45 mark, you tend to see acceptance decline a little bit. On average, just doing a national survey, the average fees are a little over $22. But again, the fee isn't necessarily as important as the value, and obviously how adamant, if you will, you are when it comes to how important you believe it is to the patient to have this examination. So, we have a variety of verbiage that's available. So please contact us to get that. But it's a really simple statement that this is, something safe and easy and fast. It allows us to see, you can't see with the naked eye. You can use comparisons like mammograms or pap smears without the radiation or discomfort. But at the end of the day, we're just helping to see, just like we take x-rays of your teeth to see potential disease, we're using this technology to help see below the surface that we can't see with the naked eye. So we know that reimbursement is a critical factor in determining acceptance, but we also know that when patients understand the value of the technology, they're more apt to accept the technology. And so I stole, and I'm saying that proudly, I stole from a practice that had 90+% acceptance, their technique, which was very methodical in their approach to understanding what was working, what wasn't, verbiage, when, where. And what they came up with was, I thought, quite creative. And it started with the front desk. So patient comes in, normally they're signing their name in or checking in. The front desk person is, hey, thanks for coming in, Mr. Smith, and giving them information, whether it's a VELscope brochure or a lamination that sort of describes what the VELscope is, or just some basic information, period, that some offices have made up for themselves. But at the end of the day, presenting something to the patient, Mr. Smith, this is something that we're going to be doing today, something the doctor wants every patient to have because we care about you and your health. Please take a second to read the information. And if you have any questions, you can ask the doctor or hygienist when you go back. Okay, so now instead of reading People magazine or looking at the phone, they're reading the short brochure that talks about HPV, which they're learning about for the first time in the connection between oral cancer. The fact that it's painless, it's fast. So one of the benefits is it actually answers a lot of questions that they may be asking in the back, which save time for the hygienists, who predominantly are the folks that do the initial exam, VELscope exam. And so now they go back. Mrs. Smith, you have a chance to read the brochure. Pretty cool. Shall we move forward? Any questions? And generally, because all the VELscope questions being answered, it comes down to, well, does insurance cover, is this reimbursed? And so what we found is Delta Dental generally has an established fee code throughout the country of about $65. And that $65 is a standard, and it's used more as a position from which to discount it, as they develop specific plans with companies throughout the country. But what we can say very simply is, Ms. Smith, the normal cost of the procedure is $65, and this is critical. But the great thing with your insurance is the most you get out of pocket is only $25. Shall we move forward? And so what they found with this approach is, number one, if it's covered, it's covered, great. If it isn't, but they're not spending time determining or finding out if it is covered or not. And at the end of the day, they've established the value associated with it, and you're also presenting it at a discount. You could definitely charge a lot more than 25 or 35, but you're providing a discount that hopefully the patients will appreciate. So, obviously, if you see something suspicious, we're going to send that to a specialist for review. Please be aware, though, that we never want to say biopsy because you don't know. So we're going to refer you to someone to further assess that abnormality. And then obviously that clinician will determine what the next steps are. So one of the things that we understand, though, is sometimes it may not be convenient to get the patient to a specialist. Sometimes the specialist may come back to you and say, hey, I don't see anything wrong. Just observe it. And you may feel differently. So what do? So as of right now, we have a service where if you provide us information on the patient, not name of the patient, but information, age, health history, medications, information about the lesion in terms of does it blanch, how long has it been, pictures under white light and VELscope, which are critical. You send that to us. We then will forward it to world-renowned oral pathologists throughout the US, including University of Washington. And they actually provide a report that provides some guidance as to what they think it could be and the appropriate treatment protocol. So for instance, this is indicative of acid reflux, and therefore a recommendation is get them on a antacid type of medication and then follow up appropriately. So it's very comprehensive in terms of the recommendation, assuming the information that's provided is complete. And that is a service that we provide for you at no cost. And it's unlimited, but at the end of the day, what we find is it's really very few patients that we get from our practice, because most of the time, if you follow the normal protocols, you should have a pretty good sense if it's something of concern or not. So, I started off by talking about how oral cancer rates have increased, and from that, they're associated with HPV. Obviously, the more effective we are at screening, hopefully we can have an impact in terms of reduction of deaths associated with oral cancer. But at the end of the day, the most effective form of reducing deaths associated with oral cancer is educating the population. And one of the ways that we think could be a great way to do that is to help educate your medical colleagues. HPV obviously is a leading cause of cervical cancer, and numerous conversations I've had with OBGYNs have confirmed they know the majority of their patients have HPV at any given time. So we have a presentation and program that you can present to an OBGYN to help them understand this correlation, not only between obviously oral cancer and HPV, which they know, they just don't know how prevalent it is, but then from that, how we can transfer that patient to the dental practice and obviously make sure that, yes, they're getting screened for cervical cancer here, but we want to make sure they're getting screened for oral cancer here. And this is how we do it. And we have a technology that's beneficial and effective and safe. And again, inexpensive. You tell an OBGYN that we have a test that's only $25, they're like, why isn't everybody doing this? So again, something that we can provide. Here's another example. Sorry for the sort of the blurriness of it, but this is an example of a doctor-coordinated screening event at a local hospital that not only where they ended up screening over 150 patients and generated new patients because of that, but more importantly, I say, is that they actually educated the medical staff that were at this facility, which led them to end up referring more patients to the dentist actually that coordinated. So just think of, I think, opportunities again that can get you in front of the public that hopefully can increase awareness. And at the end of the day, awareness is going to have an impact in terms of the deaths associated with this horrible disease. So thank you so much for your time. Thank you for your purchase of the VELscope and joining the VELscope family. We are confident that if you incorporate this into your practice, you make this a priority in terms of the care that you offer your patients. Not only are you going to achieve gratification, not only hopefully your patient's going to be happier, but we literally can have an impact with this disease that in the long run we know will impact hopefully the overall health and more importantly, the reduction and elimination of this horrible disease. Our contact number is here. If you have any questions or concerns, please do not hesitate to give us a call. Have a great day.